Cancer is a deadly disease, and some of you, unfortunately, including myself, have witnessed it, close, first hand, second hand. We've been trying to do something for the past 5 decades, and there's been some success, but by and large, it's still a lot more work that needs to be done. Unfortunately, in oncology, in cancer, one shoe doesn't fit all. It has to be personalized, individualized. And it's pretty clear that the future of cancer management is going to be precision oncology, personalization, N of 1. And that is driven by biomarkers. But for a right patient, at a right time, giving the right medicine with the right dose, and monitoring it throughout is mission critical. And it's not just the patients, right? When first time you hear about the cancer, lot of traumatic experience happens personally, physically, emotionally, mentally, financially. And it's a very difficult, situation. First, there is a denial. Then there is a aspect of why me? Why now? What did I do wrong? Then you get over that emotional trauma, then you try to figure out. Fortunately today, we have a beautiful panel which is going to cover many of those aspects. We have a, oncologist as we have the caregiver, who faces this day in, day out. It's a beautiful panel that really addresses, that. It's not just the medicine, like we always say, meds are better than medicines. And meds is a short form for meditation, exercise, diet, and sleep, is also very, very important because it's a battle. You have to fight the battle. There's a lot of resources, scientific, technological, medicinal, etc. But at the end of the day, the center has to be the patient and a support infrastructure. We also have a health hero on the panel, who is not only fought and won the battle, but also is helping through a support group infrastructure he created others. And those truly are health heroes because their experience comes from having the scars at their back and the success. That's inspirational, that's motivational, and that's very supportive. So I couldn't ask for a better panel to answer this question. 3 keywords for the community: you need good content, and CWC has a lot of them, but presenting in a fashion, and this is where AI comes in very handy because nobody has time. You have a question, you want to get that question answered, and immediately that, that instantaneous answer, and that's where AI-enabled technology. As I stand today, I feel very optimistic and very confident that we will not find cure for cancer. There is no such thing as that. But can we make cancer a manageable disease? Can we make cancer a chronic disease that you can live with? And I will tell you that it's very exciting, and I'm optimistic because the action is happening at the intersection of science and data science. That rather than driving looking through the rearview mirror, which is what cancer has always been so far, we are turning this into predictive oncology. AI is helping us anticipate what's going to happen in future and take corrective actions now so we can manage the disease better. 3 keywords, the AAA, making it actionable so that the doctors, which we'll talk about, barely get 5 to 10 minutes with the patient. And they're bombarded with so much of data, so much of information, it's almost impossible. It's like a captain in a cockpit taking a decision, flying the plane through turbulent plane, and I'm speaking on your behalf. But, that's where I think AI, and I'm not saying AI as artificial intelligence, it's almost AI is like augmented intelligence to support them to make critical clinical decisions at the point of care. A solution for managing cancer comes from that intersection of deep science and deep technology, and that's what we do. I think some of the stats are mind-boggling. US now has touched 2 million cancer patients last year, new cancer patients. The number of deaths, incredible, and it's a global problem. Worldwide, you have over 50 million worried cancer survivors. That number is about 11 million, in India. Cancer sometimes, you feel that, oh, it's a hereditary. It's only 11%, and correct me if that's the case. 89% of the time, it's a lifestyle, somatic, what you do, what you eat, this stuff, that kind of stuff, that's preventable. Okay, and the whole vision behind CWC is to figure out what it takes to be able to do so. Unfortunately, you get diagnosed, you go through all the trauma, we'll, listen to the stuff here, but then there is a phase of wait and watch, and that watch is damn painful. We need to do something better, perform something, predict and prevent. Those are the three key words. Wait and watch, I think, should be the thing of the past. Next decade, this is going to probably make the difference in the way we manage it. Current detection falls short. The standard of care is, the PET, CT, MRI. They cannot detect until the tumor has grown to about 9 to 10 millimeter. That's about trillion cells. A gram of tumor sheds about 1 million cancer cells every day in the body. Unfortunately, the science had not evolved to capture that. The root cause of cancer deaths is reoccurrence. Reoccurrence happens because of the process called metastasis, where the cancer tumor cells are shed. They are the fugitives on the run. They go and settle somewhere else. So you may have treated cancer, let's say the lung cancer or a breast cancer, but those few evade the system, evade the medicine, they go and settle somewhere, and then that growth happens. So reoccurrence is a fact of life. Unfortunately, the science and technology, we didn't know where it's going to come from, when it's going to come from, how bad it would be, and that thing actually is really, sort of the shortfall. At one cell, we have this evolution, and some of these might be a little interesting. Ability to capture from a simple blood draw, okay, that capture that 1 in a billion circulating tumor cell that capture the stuff, then do the next generation sequencing, some of you may have heard, and then do multi-omics, genomics, proteomics, transcriptomics. Cancer is like an elephant and 6 blind men. Each one of these science tells you a little bit, but nobody has figured out all of it together. And to tell the doctor, the oncologist, what do we do? What's the right medicine? Would it work? Would it not work? Selecting the right medicine. And oftentimes, in advanced cancer stage, there are no guidelines. Right? So you have that stuff, right? So that's the science and technology part that we had. We would like to, request the doctor, so request each one of the panel members to do a presentation, provide their perspective, and then at the end we'll have some questions and answers, and then do a little demo, and hopefully we'll compact it in a way that will leave some time for the M of the medicine, stuff, so that Dr. Sachin hopefully will end it with that. Okay, so with that, let me introduce.
So we were just going to cover a few from oncologist perspective. What happens after a cancer diagnosis when patient or a family member is given a diagnosis? It can be very overwhelming. But first few steps are very crucial. It's always good to stay calm, get all your information right. Also, you need to understand the diagnosis. We often go through a lot of emotions when you have a devastating diagnosis like cancer. But all cancers are not terminal. Cancer is not a death sentence. That a lot of cancers still can be cured. And with modern medicine and technologies that we have, a lot of cancers have become like a chronic illness, which can be managed, and patients are living longer and longer these days compared to 10 years, 15 years, 20 years. Even the treatments have improved so much that your side effects from the treatments are also much more manageable. We see less patients going to the hospital. So it's times have changed and things have changed. So understanding what your cancer is, type of the cancer, staging, all of that is very important from the get-go. Once you have a diagnosis, an accurate diagnosis is always important. So confirming the stage, getting the studies done, also having your family involved from the very beginning is so important because they are going to be your pillars in your path of healing or your path at this cancer journey. And timing, some cancers need to be treated right away and some can wait until you get the full diagnosis, full information. What are the do's and don'ts after a cancer diagnosis? I always encourage my patient to get a second opinion. Once they come talk to me and I give them my plan and I say, at any point of time, you're welcome to go for a second opinion. You let me know if you want to go, I'll arrange that for you. Other thing I always encourage my patients is keep a journal. You're going to forget what happened, how things happened. Sometimes the timelines about how situation happened or how your symptoms progress also important. So having a timeline written down is very important. And always bring someone with you for the appointments. A lot of my patients are older patients. They don't have a family member to come all the time. But I kind of know a lot of patients' background. I tell them, hey, call your daughter, call your son, because I might have already identified a person who can help guide them, or at least be a second set of ears. Because Mohan was saying, we get 10 minutes, 15 minutes, new consults, 30 minutes. We have a lot of things to cover. I want to get past the diagnosis. I want to get to the next best step, whether it's a surgery or treatment, whatever it is. So, and I need that time to be able to discuss all that in that limited time frame so we can get moving. And then once you have your team of people with you, have your questions, I always encourage, please bring your questions. Then I ask them, my patients, okay, what questions do you have? And then sometimes I listen to the question and say, okay, then I know what I need to cover when I give my discussion, my recommendations. What are the don'ts? Of course, don't panic. We kind of don't rush into treatment. These days, there are a lot of miracle cures that we hear. Please don't go that route, because I have lost patients who have taken medication in addition to the cancer chemotherapy. They've started something different, and at the end, your liver is failing, your blood counts are not working, and when you ask further, I'm like, are you taking herbal medication? Are you taking anything other than so show me your medication list. And then they would say, oh, I started taking this ivermectin. I started taking fenbendazole. These are the two common names that come up in a lot of different scenarios. And don't start taking anything unless you talk to your doctor. That's always a big thing, because you might not know what interactions are there, what medication can cause, what side effect. So it's very, very super important to do that. Do your research, but bring it to your doctor. And if your doctor approves, then yes, please take it. Cancer stages, stage 1 to stage 4. Stage 1 is localized. Usual treatment would be surgery. Sometimes you might need to get some radiation. And recovery is very quick, minimal side effects. And after the first treatment is done, then you'll be monitored. Stage 2 to 3 are called locally advanced. You may need surgery, chemotherapy first, or chemo and radiation first before you go into get surgery. Of course, with chemo, side effects that comes up are fatigue, hair loss, but still stage 1 to 3 is a curable cancer. When it comes to stage 4, cancer has already spread to other areas. Most common treatment would be a systemic chemotherapy, meaning chemotherapy through your veins, or sometimes if you have a targetable mutation, you may still have an oral chemotherapy as your option, immunotherapy, targeted therapy. So here, the focus is on quality of life, get the very basic minimal treatment to be able to prolong the cancer spread or the time that you are in the next level. So for breast cancer, I can say that stage 4 breast cancer, we can still give hormone blocking agents along with certain targeted medication we call CDK4 inhibitors. So that can still be done, and not all stage 4 cancers need intravenous or through your vein, the chemotherapy that goes in a bag. So we can still, in a patient with a hormone receptor positive breast cancer, we can still give oral pills for very many years before they need, stronger chemotherapy. But again, I tell my patients, my stage 4 patients, it's a marathon. You're still running the race. It's not the end. For stage 1 to 3, I'll say sprint. You have to get strong chemo, get your surgery, get to the other side. But so that's how when patients don't know how they want to navigate this, this is how kind of talk about it. Briefly going over, common cancer types. So breast cancer, a typical way we do is mostly surgery. They may need chemo and radiation depending on the type and the extent of the disease. What are the concerns that patients have, especially with breast cancer, body image issues, and survivorship groups and support groups, and also talking to patients when the similar situation can help patients navigate this situation, especially with the breast cancer. In lung cancer, treatment like targeted therapy, immunotherapy, surgery, in select cases, one of the common things the patient experiences breathing difficulty. Of course, some therapies focusing on that would be something that comes up and talked about, and what the patient would be helped with. Colorectal cancer, most of the colorectal, if it's stage 3, you end up needing a stoma or a colostomy bag, which becomes another, added concern with the patient. So need a strong family support to be able to help manage, and also to how to navigate that. And when you go outside and, outside and help, they may need help with that, and support systems through that. Prostate cancer is a pretty, less aggressive, I got to call it. They tend not to spread for a very long time. They can be watched. Symptoms are very, minimal at the early stage. Cervical cancer is another cancer that young women struggle with. They might not tell anybody that they have vaginal bleeding until year 1, year 2, by then it is already locally advanced. I've had, I just want to mention the colorectal cancer. I've had patients young in the 30s and 40s comes with, oh, doc, I have had this bleeding, rectal bleeding for 2 years. They would think it's hemorrhoids and not get care for. So had they had noted that before and spoken to a physician, their situation may have been different, like early stage versus locally advanced. So, this is on the side of the prevention and screening wise. What are the advances that we have had recently that has made cancer a much more treatable disease? So, targeted therapy, if there is a specific mutation, like once Mohan was saying, mutation, if the specific, you don't need systemic chemotherapy, which has strong side effects. You can have very targeted medication. For example, for lung cancer, it's an EGFR mutation. You can have a EGFR mutation and have a drug that takes care of that. And I have had patients, like I think my longest patient on a EGFR mutant lung cancer, she's been on the drug for almost 10 years now, and no disease growth. This is a stage 4 lung cancer before the advent of all these mutations, mutation and the inhibitors. The prognosis 6 months to a year or two, if with treatment with chemotherapy maybe 2 years. I've not seen anybody go past 2 years. with standard of care chemo. But with these kind of medications, we are able to have a patient live longer and have a reasonable quality of life. CAR T cell therapy, amazing. I have a patient with acute lymphoblastic leukemia, which is like a death sentence. You give strong chemo, get transplant, and if it comes back, then that's it. There was no more treatments. So CAR T cell is up and coming, used in some of the blood cancers, and patients have gone into remission. It is almost curable, I want to call it. Immunotherapy, amazing things. I have seen the difference because when I started with my fellowship and now practicing, I am able to, if it works, I'm able to provide 3 to 4 to 5 years of additional life for a patient when immunotherapy is able to work. So immunotherapy, how it works is it activates body's own immune system to fight against cancer cells. So you'll hear in TV, Keytruda, Opdivo, these are the common medications that we use and use it for a lot of different cancers. And many times when patients are even not able to take systemic chemotherapy, which are stronger IV medication, older patients, I'm able to give them the immunotherapy and they have much less side effects. I think the oldest patient I ever gave immunotherapy was 97. And I was like, he had one of the worst diagnoses, so he didn't live very long. But I was amazed that I could still offer something like that. So our modern medicine have gone so far ahead that we are, as an oncologist, we are able to provide all these outstanding medications, outstanding systems of treating patients, so we can help support our patients for a longer time. Coming to precision oncology, so Mohan was talking about next generation sequencing, biomarkers. They give us more personalized care to be able to not go to the next chemotherapy, but pick out if they have a ESR-W mutation. This is a newer hormone receptor, positive breast cancer. They have that mutation, and you can, instead of going to a different treatment, if you have that mutation, if you find it, you're able to give that specific drug. So, and you don't find that for every patient, but these are very patient and specific to patient. There are times that I might want to talk to a patient to just say, okay, I'm going to give this chemo. Your blood work is good. Let's go get chemo. And patient might just stop and say, I don't want to do this, and it might be middle of the treatment. So sometimes I have to stop at being a physician and sit down by the patient and listen to what they have to say. And I've done that, and sometimes you give them a new lifeline to hold on. And they may still will continue your treatment, but giving that extra few minutes, asking them what is the real deal that's bothering them. It's like, okay, it might be a family member's graduation, a children's graduation, or will I live that long? Or will I be able to get to that? Or I need to go to Mexico and see my mom, can I stop the treatment? There might be simple things that they're afraid to ask us or don't want to stop their treatment so they can get to it. So sometimes we as doctors have to stop and sit with the patient and listen to them. And I do that so often and especially in the cancer world, I have to do that, and that mental health being and knowing that your physician is by your side to take care of you with your medicines as well as your mental health. Many times I'll say, maybe all you need to do is just get out, go for a drive. I know you can't walk. Have your son take you in the car and just sit outside of the park, go to the beach, that maybe that's all you need, So just giving them ideas, sometimes that might even just help. Being able to come to see the doctor first thing in the morning because they had to drop the kids off or come back after the clinic, So whenever we have, I'm able to, I let them say, okay, she can come anytime. I'm here till 4, she can make it, if she misses her appointment 2:30, that's okay, come in, So practical support with appointments, medications and stuff like that. I think family members are going to be the pillar of care, of their support. Other thing that I sometimes don't get too much into details is patient is there, but your caregiver, what are they going through? So we, in our cancer center, we have something called Monkey Business, which is a cancer support group for children of patients with cancer. So we have once a week, our social worker leads that. They bring all these children and they have some activities, and they have little kids as 5-year-old till 12-year-old. And they talk about cancer, what to do and what not to do, or how to be around your mom and dad who has cancer or a grandma who has cancer. And I feel that helps little kids a lot. We have another small service called Jessica's House that's more for patients who passed away and cancer support support for the families after the passing. So we are kind of involved in that too. So those are very, very important for the caregivers. It takes a village to help with the healing, so your community. So I always tell my patients, if a neighbor is asking to come drop you off and help you with the appointments, take it up. If they're going to cook you pasta, just ask them to get help. Don't be afraid. Don't be shy to ask for help, because even small things can sometimes be big deal, So support groups, friends, family, survivor networks, all of this are going to be your bigger circle, which helps in their cancer journey. Many times my patients ask, "Doctor, why do I need to go see my cardiologist?" I said, yeah, you got to do that because, there might be some side effects that is related to cardiology or a lung doctor. So I always encourage, make sure that you're seeing your different doctors, your multiple doctors, whoever is in your panel, always have their list of information so you can provide to your doctors so they can all connect and come up with a plan. So it's the same thing along with that. One other thing I tell my patients, even if they go for a second opinion or not, I have a lot of patients that I care for with Stanford and UCSF, and we always encourage, and when we discuss between doctors, tumor boards. They are of a big help to us in guiding the treatment. This is on the medical side, more so. So if a patient have to go visit Stanford physician so that they can have a second opinion, like I said, I always encourage that. Nowadays with telehealth, that has improved, that patients don't have to drive all the way. So which has helped a lot. And they say, okay, just make sure that your 3-month or a 6-month appointment with Dr. So-and-so is there. Even if we'll send the scans over, just make sure that we're all in the same board. So that also helps in getting into clinical trials. So if you're already in a system, and if something comes up or the current treatment is not working, clinical trials are hopefully available and they can be looked at if you're already in the system. So that's one thing I always tell my patients, that, if you have the means to kind of travel to, a tertiary care, it's always something that you want us to do. This is some information regarding where to look. Stay informed. So cancer.gov, NCCN guidelines, there is a patient guidelines in NCCN as well. Those are the places that I would always refer my patients to. Other major U.S. cancer centers, Mayo Clinic, Memorial Sloan Kettering, Tata Memorial, of course, back in India, they all have good information on the website. That's where you should be looking at, or where I refer my patients to for getting information. Practical, like a financial issues. So understanding your insurance, making sure you have coverage, getting a better health plan is always important. Always, if you're in doubt, always look for a financial planner within your cancer center, also a social worker. They may have more information from the get-go to help navigate. As a doctor, I might not know anytime. As soon as I hear a red flag of something is not right, I'll say, okay, let me have you see my social worker. They can help guide with, your FMLA or disability and things like that. So and they might be able to even have you find extra funding or something through Leukemia Lymphoma Society or different cancer foundations. So that may be something always to ask. Living with cancer. Some finish treatment, some have to continue their care while managing more so like a chronic disease. You have to embrace the new normal.
I am a part of BANA, which is Bay Area Indian Nurses Association. And I've tried to be a voice and advocate for these patient population who need the specialized care. from a nurse's perspective. So when I'm talking of a patient coming in, we are talking about a patient who already knows what his diagnosis is. He knows what his treatments are. He knows what is going to happen to him in the next few days. But that is not what his, we have to understand, that patient, when he comes into the hospital, the first face that he sees is a nurse's face. We are the one who will be going there, taking care of those patients, trying to understand what their understanding of that disease is. Do they really know what is going on? They do. They have a lot of information, but do they really understand it? What their life is going to be in the next few days. So understanding that patient's perspective and going from there, how they're going to apply that knowledge. It is different to know a certain thing, but when you're going through it, you know that you're going to be having a different, for example, if you're having a chemo, a melphalan, which would be causing mucositis, the patient knows the side effect. We are all well educated because we're going to be reading about it, we're going to be knowing about it, but then we know mucositis is an issue. But how we cater care to each person, like for example, if you have an Asian patient, in Chinese population, they would not want to have cold water. They want to have hot water. But when they are having this melphalan, we want to make sure that they're not having hot water because we want to cause that vasoconstriction. So we're going to have them stuff their mouth with ice. So we want to avoid that mucositis. That is what we start 2 hours before that chemotherapy. If it is an Indian, we would say, hey, we know the culture, we know their biases, we know what they're doing. So we want to say, we want to reduce that, spicy food intake. So those are the things. We cater that care to individual person, making sure that they understand how to go through that journey. So that is what it means to understand and basically apply. And that is where we come into our picture. In that last 10 years that I've been here, I could categorize my patients in two main categories. I'm talking about patients who have that spiritual care and patients who are looking at it from a cure perspective. So when I'm talking of spiritual, mind you, it is not religious. What I'm talking of spiritual is basically understanding that disease, understanding the process that's going to be happening, understanding there's something bigger than the disease and you're going to be walking through it, how you're going to be caring for it. That is what I'm saying when I'm saying the spiritual practices. So patients who fall under the category of spiritual practice versus a patient who is looking at it from a cure perspective, it's always seen, there are studies that support that these patients do much better than patients looking at it from a cure perspective. So when I'm talking of cure perspective, it is more like a survival mode. Like there is a disease, these are the things that I need to do, and this is what is going to happen to fix this disease. But when I'm talking about the healing part of it, is that all that it is? It requires, like Dr. Jinsi mentioned, it requires a village. It requires a lot of people to support you through that walk. It requires, so it is the well-being part of it when you are taking that disease. Like, for example, when a patient comes in and he has a VP16 or he has melphalan or a few other chemotherapies that he's going to go through in the next few days, it's going to change their lifespan. It is not going to be any more normal. It is going to be, he's going to be dropping his blood pressure. He's going to be having cystitis, which might require him to urinate more frequently, have more fluids, teaching them that process. How are you going to be, what are you going to do the next few days? And it is not just that person. It is a person and the whole village, their family who's going to be taking care of them. There are so many aspects to it. Cancer has so much trauma with it that it does not require only curing, it requires a healing aspect of it. To take away that trauma, to take away that pain that comes with it, that requires healing. So that is when I say, when we are eradicating a disease or a problem, it's not about just eradicating that disease or a problem, but basically trying to understand the process. And it is easier for me to say, I have seen these patients walk through this journey every single time. It is easier for me to say, but it is harder for that patient who's going through it. So you know what? Understanding, trying to listen to what they're trying to say, that makes a whole difference. So when I'm talking about healing, I'm talking about physical healing, your mental healing, your emotional and your spiritual healing. So what I'm saying when I'm saying it's physical healing, these patients, when they are getting these different chemos, these different treatments, the pain, the side effects that come with it, that requires so much more care. Like if there is a pain, we are going to be giving them the chemo, but understanding that giving that chemo is not the end of it. The inflammation that will come with it, the side effects that will come with it, it requires so much support. To be able to support that medically, physically, that is a physical healing part of it I'm talking about. Mental, the support, when the patient is going through this, the pain, the racing thoughts that you cannot stop. What is going to happen next? How do you stop that? How do you stop a patient from feeling, okay, what is it? There is so much trauma with it that the mental feeling never goes away. What if this person that I'm living with is not going to be here tomorrow? That feeling, that mental, we cannot stop that, but how we can support it, how we can make sure that this patient understands. So that is where the mental healing comes from, the emotional aspect of it, and the spiritual guidance that is needed. So it requires a lot of aspects that needs to be put together to make that healing happen. My role as a clinician is to be able to support not only with the symptoms, but be able to look at their psychological and their physical and their spiritual well-being. Simple things like when you're going through all this, you're going to lose your appetite, you're going to lose so many things. Your own physical image is going to change so much. Like, for example, with the cell transplant, sometimes you might have the side effect called graft versus host disease, which is going to be not only, and especially if you have it on your skin, it's like you won't recognize yourself. It's like your skin is burnt completely. You do not recognize yourself. How do you see yourself in the mirror and know who you are anymore? So being at peace with that, being able to accept that, being able to understand what the changes are going to be and how it is going to affect you, your family members, how you look at it, that is the aspect we need to work with. It's not just curing the disease anymore. The quality of life, you're going to be so exhausted. It is going to take you so much time to do the same task you did before. The mental fogginess, which is very common. And then that is what causes frustration. The curing part happens sometimes and it does not, but the frustration that comes with it, how do you walk through that mental fogginess? How do you do your regular things that you were able to do? So many patients come in walking, talking when they come in for the treatment, but when they're going back on a wheelchair because they are exhausted. Their body has gone through so much that they're not able to even recognize themselves. People who are there in the hospital for around 30 days, 25, 30 days, when they're going back, it is exhausting. So how do we support that? That is the areas we need to start reaching out to. So my role in promoting that healing is basically listening to that patient, understanding what their values are. For certain patients, it's essential to have their village around them, to have more people come visit them. That is how they promote their healing. But we also have to be sure that we are educating them that when this chemo starts, when this treatment is starting, there is a chance that you might be neutropenic. There is a chance that you are going to be pancytopenic, by which I mean is they might not have enough white blood cells to support them. So they are neutropenic. So what happens? Do you let them have that village around? You do not want a lot of people around, but whoever you have closer, make sure that they're cleaning themselves, they're making their hands are clean, they're washing their hands more frequently. You don't want to have kids around sometimes because kids are sometimes a ball of germ. They touch around, they don't realize. So, you have to be aware of all that. You have to teach them that. You have to tell them that. So modifying it to know how you would support, that is how we would want to promote that healing, empowering them. So it is not about me telling you this is what your treatment options are, this is how you're going to be doing it, but giving you the options. Hey, this is a treatment that you're going to be getting. You're going to be getting this treatment. How do you want to do it? How should I support you do it? What do you want? How would you feel comfortable? What do you want that I could do to make this journey a little easier? So giving them that treatment option, empowering them. And sometimes the patient might say, you know what, I'm done with this. I don't want this anymore. If that is what it is, then that is the quality of life you want. Yeah, let us support him. Make it we want to give them that 100% of quality that they can get. If that is what they want, go. If they want a palliative care, yes, go ahead. But how do we do it? How do we make that journey more comfortable? It is not easy to go through this journey. But when you have the right people with you, you have that support system with you, that is when this journey is not
initially with the cancer. It was a very, it hits you from, I didn't expect, it hit you from surprise. I thought I passed a kidney stone when I started develops the symptoms back in 2011. I thought it was a kidney stone that I passed. Very painful, but it wasn't a kidney stone. But that's what started the process. And eventually, the CT scan, blood test revealed that, in fact, I had cancer, a big cancer. The tumor was double the size, the doctor said, of what they normally see. So I went to one support group during that time. And I took targeted therapy that was mentioned. That it took me a while to ask how many nodules they found in my lungs. And it was a minimum of 15, 16 that I was told. In that time, I went to one support group meeting. And in that support group meeting, they told me about the second opinion. This is all in San Francisco now. And I went to it. They give you a free second opinion that was brought up earlier about second opinions. And I went to it because the mass came back in 2014 in my right lung. And I talked to my doctor. She was unsure we should have a surgery. But I said, and then I told her about this network, and she said, sure, go to it. She supported that. So I went to it based off that support group that I went. And I did. I ended up having surgery, and it took the mass away. And that was 2015 now. And that's when immunotherapy came around. And so at that point, I still had my support system on my own. Friends, professors, fellow counselors that I worked with. I was an academic and career counselor at San Francisco State and City College. So that's where my main support was coming from. In 2019, a month after I became chair of my counseling department at City, the symptom I had been getting symptoms in my arm, little twitches. And I thought they were twitches. And turned out, she called it, these are not twitches, these are not spasm, these are seizures that you're having. So it turns out that they found the original cancer had metastasized to my brain in 2019. So I'm telling you, a month after I became chair, that summer, opted for radiation first. That worked to us a little bit, but not as good as we had hoped for. So I had surgery in August of 2019. I was in recovery the rest of the semester. I developed embolism. The day I got released from the rehab center, which I spent 3 weeks of, starting new because I had to start from walking. It was almost like from baby to adult very quickly in 3 weeks. The day I got released from the rehab, I was back in ICU that night because I had developed some pain that was shooting up. Started in the morning. I told the Kaiser staff in Vallejo, the rehab, but they said watch it. They gave me some Tylenol, but it just kept increasing as the day went on. My daughter had picked me up at that point. And so we got home and it kept going. So I called the advice nurse and gave them my history. They said, based on your history, you better come in. And I did. And it was saddle pulmonary embolism that I had, telling me, I can hear the doctor talking about fatal. This could be fatal. This is catastrophic. But I kept on. I'm a fighter. I'm a peaceful warrior is what I am. And at that point, I said, okay, let me join this time. So I went in it full time, right? So what are some of the benefits of joining a group, as we talked about, right? It lowers stress and anxiety levels because you're sitting there with other people that have cancer. It may not be the same, and as I've said, every cancer is different, every patient is different, every reaction is different, but you're walking similar journeys, right? Your emotional, psychological being gets affected, right? So you're sharing experiences, right? You hear from other people what they're doing, even though it's a different cancer. You hear, and it gives you encouragement. It gives you strength to go on, move on, and you get empowered, and it gives you hope. Ultimately, it gives you hope. It also provides emotional support, right? Again, you're with a group. You feel you have a sense of belonging with this group to somebody who's going to similar journeys with you. You know, you have that support, even though, you know, you disband after you have your meeting, but you still, you take with you what you learned from that 2-hour meeting that we would do, right? And it's full of empathy and understanding. People who have gone through it, going through it, they understand, right? Your outside people, you know, they'll look at me and say, "Oh, you look fine. What do you?" Yeah, but you don't see the internal side. You don't feel the internal side, right? Yeah, the appearance is one thing. The internal is a whole different part of the being, right? So you have people who can empathize. The compassion, as you mentioned, you know, it's much needed for this process. And it's a safe place to talk and express yourself, right? As men, we have a difficult time many times to talk about our soft side, our emotions, because, you know, the society, it looks like a weakness when you provide that. But these groups, it allows you to open up. Palliative care support group. So we would talk about nutrition, you know, the evils of sugar. You know, we talk about alcohol and the tobacco. So we share resources. She would bring in guest speakers sometimes. And it just helped each other, again, moving to the next step, the day by day. And studies have shown that it does improve quality of life. You know, I've seen some studies with nurses specifically where, you know, it added a few years to their life because, again, you have something to live for, right? You have purpose. You have people supporting you to that next goal, you know. The first conversation was about buying time. I said, wow, buying time. What does that mean? You know, it was like a death sentence. You know, at that time, kidney cancer was pretty deadly. And, you know, one of the slides said, Dr. Google. That's exactly what I did back then. You know, went online and looked at the information. It was dismal. It was like 5%, you know, would survive 2-5 years. But I told myself from the beginning, I want to be that 5%. You know, I had that fighter, warrior mentality. And, you know, not everybody, you know, I know somebody who had this exact same cancer as me. He, less than 2 years, he passed. And, you know, his wife will ask me, what was your secret? What was your secret? I go, I have no secret. I go, I can tell you what I've done, the process that I've gone through, the frustrations, the relationship I have with uncertainty, because every scan that you go to, you know, every test that you would go, even though you're in remission, you never know, because you never know when it comes back. You know, I had that 2014 and 2019 has examples of never knowing. Things were clean, and then all of a sudden, it's back. One of the biggest part, again, is that sense of belonging, that community we have. That's us in 2019, 20. So we would have, even, you know, outside of the hospital where we'd meet in person at the time. This is pre-COVID. Then we'd gather at somebody's house and have meals. This is on a Saturday that we had, and we had fun. So, you know, you build this this community of fellow people that have gone through the journey of cancer. This long time relationship with people. You know, then COVID hit, and we went online. And then it disbanded when the doctor got a new position, and she wasn't given any time to run the group. And that's when I said, okay, I got a master's degree in counseling. I've been an academic and career counselor. Let me transfer my skills there. So I put together a group. And we had at one point about eight fellow patients, fellow cancer warriors with me. And we did that for about 2 years until last year when I got into the doctoral program. Just the demands of the program were too much to be consistent, but it's something I want to go back to. I mean, just Monday, I spent 4 hours with a friend of mine who just got diagnosed with cancer. So, you know, you talk about the day-to-day, walking with people. I still do that. I still get calls from people asking me to talk to somebody just because, you know, in the little bit that I can give, the why me at the beginning was why me. I was doing everything right. I was working out, eating right, peaking my career, to the why me now, the transformation of why me, to be able to help people, to transform people's lives, to give them hope, to give them something to live for, those 4 hours that I spent Monday, well worth it. I didn't even, the time was not a factor for me. It was a fact that I can help this person, give them some comfort, some relief that, and he used to look up to me, and now he's with me. I said, we're colleagues here. I'm no better, I'm no higher than you. We are together in this, So I can't emphasize enough what support groups can do for people.
What makes us think that lifestyle is so important? It is because we have evidence for it. What is the evidence? This breast cancer is the commonest cancer in women here. It occurs about 1/3 of the time in China. So it's like 300% more common here. When you take women from China and they come and settle in US, after 10 years, their incidence of breast cancer approaches that of US. Their genes didn't change. It's purely what they ate and what their activity level is, what their emotion is. So the genes didn't change. Just by shifting across the Pacific to America, boosted their cancer incidence so much. The other thing is when a child is born to an Asian immigrant here, that child has about 60%, that child actually has the American incidence of breast cancer risk rather than what the mother's incidence was when she was born in China. So we know that location and lifestyle matters. The other thing is, very strong indicator is Dean Ornish's experiment on prostate cancer. So he took men with early stage prostate cancer that you could wait and watch and expectant treatment, and these so one group and they were matched. So the group that he was in, the active treatment group, were on a low fat, really low fat, 10% fat, plant-based, strictly plant-based diet with 30 minutes of exercise a day, 5 days a week, mental relaxation like yoga, meditation, and social connection once a week with a social worker and group therapy. That is it. The other people continued on whatever they were doing. Neither one was on treatment. Just 6 short months later, the people, we measure the marker PSA. The treatment group, their PSA went down. The control group, the PSA went up. And the most important thing is when he took the blood from the people who had been on this vegan exercise group, meditation group, and he dropped it onto cancer cells, those cells were destroyed, showing the potency of the lifestyle. This is the potency of lifestyle, that it can actually destroy cancer cells. And the other group, the cancers actually progressed. So these are 2 instances why we think lifestyle is so important. So what are the pillars for lifestyle? The American Institute of Cancer Research says, if we don't do anything else, if you stop smoking, there are still 30 million people in America that smoke, and then they give off secondary smoke. If you protected yourself from this smoke, you're already significantly much less for cancer risk. If you were if I'm not obese, or if the patient is not obese, that itself is a marked risk reduction. And the other one big one is exercise. If they did any exercise, that would be a huge contributor to combating cancer. In fact, one study said women with breast cancer, when they exercised, their recurrence rate is much less. In fact, a study of 1.4 million, it's a meta-analysis done by Stephen Moore, and 1.44 million people who, he followed them for the exercise, and it's a meta-analysis, looked at the study. People who exercise regularly, they had less occurrence of breast cancer, they had less recurrence of breast cancer. If they had breast cancer and they had treatment, they had less recurrence, longer remission, and cure. So exercise benefits before, during, after treatment, occurrence, etc. So that's number one. What are the other things about exercise? Now, it decreases fat tissue. Now, there is an incidence of obesity that is about 44% or something in America. It used to be 33, now it's 44. And overweight is 75%. So most of the US population is either overweight or obese. So exercise decreases the accumulation of fat tissue. Now, fat tissue is metabolically active. It actually produces inflammation, and it actually produces, it can make estrogen. It has the aromatase enzyme. It can make estrogen, so the hormone-sensitive cancers like the breast, prostate, uterus, and ovary, those cancers are all increased. And according to CDC, there are 13 different cancers, 13 different, including thyroid and colon and all the organs in the stomach that are sensitive to this metabolically active fat tissue. So when you exercise, you actually get benefit from that. Next, exercise decreases blood glucose because elevated blood glucose and diabetes confers twice the risk of cancer. So blood glucose decreases, and also the inflammatory hormone IGF-1. Both of these cause cell proliferation, blood glucose as well as IGF-1. Now, exercise also increases stress hormones. We heard from a lot of people how stress causes cancer or promotes cancer. So exercise actually decreases stress hormones. Exercise decreases blood inflammatory markers. Inflammation promotes cancer. It decreases inflammation. It decreases fatigue. You need to have your stamina because you need to go through maybe surgery, chemotherapy, whatever. So exercise decreases fatigue. Exercise promotes endorphins, this runner's high, this feel-good hormones that are released from the brain. Exercise promotes that, and exercise promotes immunity. It causes release of natural killer cells and other T cells from the marrow that go and attack the cancer. So exercise does this many things. The next thing that's important is our psychological well-being. A lot of people have talked about psychological well-being. The important thing about all of them is that they stimulate the vagus nerve. Each one of them, meditation, deep breathing, yoga, social connection, each of them are important. Any form of meditation, whether it be transcendental meditation, mindful meditation is hugely popular, or japa meditation, whatever, is because you slow down, take deep breaths, and you let go of all the stress and you focus within. Meditation is hugely calming and beneficial. Deep breathing and pranayama, the movement of the diaphragm and the abdominal wall in and out, stimulates the vagus nerve. And it's a strong one. And yoga, when you do yoga, it relaxes you, decreases anxiety. Yoga, the other thing is when you do the asanas and the postures, you also build up stability and balance. This is huge. When people go through chemotherapy, a lot of times it's the neuropathy that's associated, weakness, nausea, whatever. So yoga is, if you want to do Tai Chi. So it's a huge part of this to do meditation, pranayama, and yoga, and social connection. Studies have shown, and this is a study between Shanghai and San Francisco, collaboration, and women who had social support did a lot better with breast cancer treatment and less recurrence than women who didn't have this. So all these are mediated through the through vagus nerve, which can also be stimulated just by humming. You can just hum. You can chant Om with a long the expiratory phase. You can also sing. Any of these will stimulate the vagus nerve. The thing about the deep breathing and pranayama is that this one action gives you control over all the other things you cannot control. There are so many things in life you cannot control. In fact, nothing, not even your kids. You can't control, right? You can barely control. But this one thing, it controls your heart rate, it controls your breathing, it controls your emotion, it controls your digestion, it controls your stress hormones. So this one thing is when we are so stimulated by the sensory stimulus around us, this one thing gives us the control that we need. And we need to control because we will be undergoing a lot of emotional information, trauma, that instability, that we need to control ourselves. This is hugely important. It quells the fire within us. And cancer is about the most traumatic thing anybody can have. The absolute, because you think if somebody says you have a stage 3 or a stage 4 or a stage whatever, is my daughter going to get married? Is my son going to get married? Who's going to look after my home? What's going to happen to my husband? It's not them they're worried about. They're worried about everybody else, right? What is going to happen to my son, my daughter, my dog? Who's going to look after my dog? So that's, the CDC report says 40% of all cancers are associated with being obese or overweight. That's a huge number if you just look at the cost of it. And that's something we can control by what we eat. It's a straight off the book, you have 40% less. That's really a huge number. So then the American Institute of Cancer Research, AICR, says the best diet for cancer prevention is plant-based. Why do they say that? What makes plant-based diet so special? It has two things. One is fiber. You don't get fiber from anything else other than plants. And you also get polyphenols. You never get that eating anything else. Plant-based foods give you polyphenols, plant-based foods give you fiber. And we will go through both of them. The other thing is when we talk about diet, there's also a lot of question about fasting. Is fasting good in cancer? And the answer is yes. Although it's just starting to come out. Even if you did a one-day fast before chemotherapy, you're supposed to be able to withstand chemotherapy better, less side effects, and the chemotherapy works better. But the simpler things to do, in excluding the fact that the patient may be in weight loss or whatever, but generally the patient has just received the diagnosis. You have cancer, in due course we will start your treatment. What are they going to do? They should opt for at least intermittent fasting. So the study showed women with breast cancer who fasted for 13 hours. So you eat from 8 o'clock to 7 o'clock, 11 hours, fast for 13 hours, intermittent fasting. The recurrence rate just by that was 30% less. There are not so many drugs that give you that kind of odds. So just by intermittent fasting, you can reduce your odds of getting a recurrence 30%. So that's, and then coming to plant-based diet, vegan diet. So there are a lot of, many studies that talk about vegan diet now. I told you about Onish's study on prostate cancer that was basically a vegan diet. That was a vegan diet, not basically, it was a vegan diet with the added criteria of very low fat, 10% fat. Good fat, bad fat, doesn't matter. Actually, hopefully it was not bad fat, it's good fat or normal fat. It's 10%. But so the vegan diet, Elizabeth Blackburn, who won a Nobel Prize for her research on telomeres, she published a study of patients on vegan diet just for 3 months. And after 3 months, she showed that in the people, not patients, in the people who were on a vegan diet, 500 genes were altered. Those that prevented disease and prevented disease were upregulated, and those that caused inflammation or disease were downregulated. This is just vegan diet for 3 months. The second study I want to quote is the study from Stanford of identical twins. And I think there were 20 or 21 identical twins. So everything, their home environment, whatever, everything was the same, just the diet. One identical twin was on vegan diet. The other one was whatever he was eating before, but not junk. I mean, they were at the end of just 8 weeks. It was not a long study, just 8 weeks. The kids that were on the vegan diet had lengthening of the telomeres. Lengthening of the telomeres means you have longevity. It rolls back your biological clock. So that's the power of plant foods. So AICR is kind and says best diet is plant-based, and actually you can, and the fiber goes to the microbiome that we have, about 5 pounds of bacteria in the gut colon, and they produce that's the food for the microbiome. The fiber that you get from plants it's the food for the microbiome, and they produce short-chain fatty acids. The role of this microbiome is to keep your intestinal lining healthy. They produce the energy for the intestinal lining. They prevent leaky guts. They increase immunity. They reduce inflammation. And the short-chain fatty acids produce a lot of neurotransmitters. They produce your happy hormone serotonin, keeps you happy. They produce a calmness neurotransmitters called GABA, aminobutyric acid, gamma aminobutyric acid, GABA. They also produce dopamine, which is your movement and mood hormone, neurotransmitter, and they help control your blood sugar. They help promote your immunity. So they do a whole lot of things. So we need to give them good fiber, good food. If you feed your gut bacteria, junk food, processed foods, you will not be helping those, and you will not be helping yourself. So in order to promote good, healthy gut microbiome that does all those things, you need to eat good fiber diet. The problem with America, it's our obesity, is 60% of our calories comes from processed foods. That's a fact. Most of us are eating 60% processed foods. I mean, you think about your samosa, pakoras, pickles, aplam, vada, gulab jamun. I mean, anything that we eat, so much of it is processed food. So we need to consciously make a change as a community. Food categories, because nuts are huge. There are so many studies about the benefit of nuts. One study that I'm quoting is from Harvard. Patients who had stage 3C colon cancer, advanced colon cancer after their surgery, were given nuts. And this was a 6-month trial. At the end of 6 months, the patients who were given nuts had a 45% reduced risk of mortality and almost 50% increase in disease-free remission duration. I mean, what drug gives you that? Nothing. So what nuts were these? These were all tree nuts: almonds, walnuts, pecans, macadamia nuts, cashews. 1 ounce is like about 20 almonds or 18 something. So 11 macadamia and 9 whole walnuts. Twice a week will give you that much, in somebody with cancer, that much power for disease-free remission and reduced recurrence. Cruciferous vegetables. This is your broccoli, bok choy, kale, cabbage, arugula, cauliflower, so many of them, right? These vegetables, they attack the cancer in every stage of cancer formation. In fact, all of them, the stages of cancer formation, from mutation, genetic mutation, to growth, to angiogenesis, to proliferation, metastasis. They all have mechanisms of attacking each of those. So now the recommendation is eat a rainbow plate of vegetables and fruits. They don't say eat this and eat that and eat that. They say mix, because if one misses something, the other one picks it up. The other thing is, when you add anti-cancer foods, there's a synergization. So there's a synergy. So if you eat tomatoes with some fat, the lycopene is absorbed better. If you have turmeric with some pepper, your curcumin is absorbed better. Men who eat tomatoes twice a week have less prostate cancer and have less aggressive form of prostate cancer. So have tomatoes at least 2 or 3 times a week, and it's cooked. When you're cooking it, the lycopene is better released and absorbed. All the other polyphenols are heat sensitive. You cook it, you destroy it. So low heat cooking. But lycopene is something that you can actually boil and have the tomatoes. Broccoli has excellent fiber, and it has been shown that people who eat cruciferous vegetables, they have less of GI tract colon cancer and stomach cancer, and also reduced breast cancer risk. Coming to fruits, all fruits are good, but there are some I'm going to mention. One is apple, which has compounds like quercetin and camphorol and fiber that's very good for the bugs, the microbiome, which is pectin. So an apple a day truly keeps the doctor away. And the other fruit I would say is watermelon, which has more lycopene than actually tomato. So have some watermelon. The other one I would mention is pomegranate. Pomegranate is used both in Ayurveda and in Western medicine, and they've shown so many benefits. And pomegranate actually gives beneficial effect if somebody is on immunotherapy. That has been shown, but it's better to discuss with the oncologist. Garlic especially have less colon and prostate, lung, brain, various cancers it's beneficial in. So I have a clove of garlic a day. It has a lot of evidence even in the lab. Then what is it in sambar that is beneficial? We have curcumin, we have turmeric, right? Sambar has turmeric. Sambar has methi seeds, which is fenugreek. Sambar has coriander. Sambar has jeera or cumin, these are all, they have in the lab, each one of them is phenomenally powerful. And you put them all together and you make sambar, including pepper. Pepper even suppresses this most potent inflammatory molecule called nuclear factor kappa B. Pepper has that, and so do jeera, etc., and curcumin. Now, tea. Green tea, women with early stage breast cancer, stage 1 or 2, if they drink 3 to 4 cups of green tea, they have less recurrence. So that has been shown, and green tea is, and the thing about green tea or black tea also has benefits, but if you mix black tea with milk, the antioxidants do not get absorbed. It causes some kind of saponification, so they're not absorbed. But if you can drink black tea with either almond milk or soy milk or whatever, you do get the polyphenol benefits from black tea also. So tea has been shown beneficial, at least in breast cancer in early stage with less recurrence. Mushrooms is another big group. The button mushrooms have been shown beneficial in breast cancer. And there was one study from Pennsylvania College of Medicine, and this is a meta-analysis of diet history. And those who said they ate mushrooms anywhere from 1/8 to 1/4 of a cup. 1/8 to 1/4 of a cup, they had like 40% less occurrence of any kind of cancer. So, Environmental Working Group, EWG, has put out a list. They come out with this list every year, finding which vegetables are safe to eat. That's called the Clean 15, and the Dirty Dozen. If at all possible, you should buy organic. So there it is, 12 in this year. Potatoes is not there, which is good because I do like potatoes. It's not there, Dirty Dozen. That's good. Clean 15, you have to eat. You can buy just as they are. And one other tip, you can, suppose you bought an eggplant or eggplant, and it's not organic. There is some suggestion that you can use baking soda solution to get rid of quite a bit of the pesticide. You soak it in the wash it and soak it 1 tablespoon to a gallon or something like a quart, 1 tablespoon to a quart, and soak it, and then you get rid of some amount of pesticides. But by and large, especially for the greens, there's no way you can wash off all the. So I think it's best to buy organic in the dirty dozen and clean 15, you can just buy it as they are. So that's my talk. So there's a lot of things we can do, and we know that they affect genetic changes. So cancer can be managed, cured, one